All right, good afternoon, everyone. Thank you for joining today's webinar, Misconceptions of VDI. It's presented by Cortec Services. My name is Hannah Westra, and joining me today is Cindy Menke and Brian Barnes. Before we get started, there is a few housekeeping items to address. Today's webinar will be recorded and will be available to you after the webinar. Additionally, if you have any questions, go ahead and pop them in the question box, and we will answer them at the question and answer session at the end of the webinar. And with that, I'll pass it over to Cindy.
Good afternoon, Hannah. Thank you so much. And Brian, great to be here today. And this is a topic that is near and dear to my heart. You can go ahead to the next slide where we can talk about the agenda and what we're going to cover today. So I think it's funny, Brian, that even as we're putting this deck together, that the first thing we said was, do we call it VDI or virtual desktop? And people seem to still be confused about that. So before we even move off the agenda, can you answer that question?
Yeah, absolutely. So a lot of topics come up in terms of what is VDI, whether it's client OS VDI or shared hosted desktops or RDSH-based desktops that allow you to get some better user density. And when we use the term VDI, we're really talking about a virtual desktop that allows different deployment modes.
Okay, so I'm sure you're going to expound on that more later.
Absolutely.
So I can't wait to hear about it. So what we're going to talk about today, and it's going to take about 30-40 minutes, and again, looking forward to everyone's questions that we can answer at the end. But first of all, perspective is in healthcare. So we've talked about this too, Brian. Here at Cortec, we've been doing VDI or virtual desktop since 2005. So it's interesting. We have a great view into what we've seen that happen in the industry over these last 12 years.
Absolutely.
So we're going to be able to talk about what were the perspectives 12 years ago, what are the perspectives today, what has changed. It's really pretty interesting. And then through that, we're going to talk about what we call VDI version 1.0, which is what we saw 12 years ago up until about 2 years ago-ish, and then how much technology has changed and played into such a more robust VDI environment that we're seeing today. And so the reason that we did this webinar is because, aptly named, misconceptions. What we're seeing out there when we're talking to customers is that the misconceptions are coming from people who still have this memory of what that early versions of VDI looked like and are really not up to speed yet on what the new technologies are and the improvements and enhancements that it has brought to that whole VDI space. So that's what we're calling VDI version 2.0, which is really a culmination of all the new technologies we've seen in the last couple of years that have really played into a comprehensive and robust desktop. Through that, we're going to be talking about also EPCs, electronic prescribed controlled substances, and how that's changing the scene. And then we're going to share our own lessons learned in rolling out VDI, because today we at Cortec, we've rolled out VDI to way more than 200,000 desktops across the United States over the last 12 years. And there are a lot of lessons learned out of that everybody should learn from. And from those lessons learned, the things that we incorporate now that we call the Cortec difference. So let's get into it. So whenever we're talking to a healthcare entity, there's always like three groups of people that we're talking to: the stakeholders or the CIOs, the CEOs, and then the doctors and clinicians who have their own perspective, and then the IT folks who have their own perspective. And it's really three different conversations because they all have different needs and wants from a VDI solution. So from the CEO perspective, it's interesting that, this first bullet point, there's a simultaneous push to cut costs and improve patient care. It's funny that, 10 years ago it was like, got to drive costs down, got to drive costs down, and it's still the mantra today, got to drive costs down, got to drive costs down, but we cannot do it at the expense of patient care. We have to do both at the same time: drive costs down, get more efficient, be more agile, and do it at the same time while we are improving patient care. Something that's new and different in VDI 2.0 now is EPCs, which you're going to talk about a little bit later, Brian. This is new, the third bullet there, M&As, mergers and acquisitions. When we did this presentation even 5 years ago, that bullet wasn't there. That speaks to how much the industry is changing with the Affordable Care Act and the expense of carrying through that Affordable Care Act and what it's forcing people to do, which is to partner up with other people to stay viable. And it's driving a lot of different sort of projects. For example, a lot of ED migrations. That's probably the biggest thing that we're seeing. VDI environments gaining acceptance within the industry. You know, that was a little bit true, 10 years ago. You had the leaders out there who were trying VDI, I would say 10 years ago. The scary part was data security. And I think everyone's past that. They have now realized that data is actually more secure if it's all in the data center, not at the endpoint. So that has changed. And it's seeing now also as a cost-cutting measure. So back to that, speaking to that first bullet, if we're trying to drive costs down, improve security, improve patient care, VDI is a natural answer. Now, the next bullet is another new bullet that has just popped up in the last 2 years, which is outsourcing to fill skills gaps. So what we're seeing is that environments are getting more and more complex, and it's harder and harder for a single individual to maintain all the skills and expertise in all these technologies that end up in your data center. So you end up with these skills gaps. And not only that, if you have one person that you're relying on and that one person leaves, you've become extremely vulnerable. In addition, if you have that one person that has that special skill, what do you do when they're on vacation? How do you fill that gap? So what we're seeing is a bigger and wider adoption to move to managed services across the board. We used to see it in just pockets of technology. For example, there was a time when we did a lot of managed services specifically around NetScalers, and we're doing or specifically for level 3 support only. What we're seeing now is more holistic adoption of managed services for entire environments and for level 1, 2, and 3 support. So bigger adoption there. So Brian, from the doctors and clinicians, doctors and clinicians, that hasn't changed either. So instant access to patient information at the point of care. That was true 12 years ago, it's true today. No one wants to think about technology. They don't want to have to count how many clicks. They want the clicks to just go away. They want systems to just be intuitive and know that you walked up to the computer, you are who you are, and just give me my data. And we're getting closer to that these days. It's kind of funny. The other thing is they want a consistent experience from device to device. Nothing drives anyone more crazy, whether you're a doctor, clinician, or someone like me sitting at a desk all day. If I move from one device to another, I want my icon to be where I left it the last time. I don't want to have to look at my desktop again and find that icon again. And that's important. When you're counting seconds to get to patient data, that's critically important. Now, the third bullet there, the innovation that we're seeing in the integration of personal mobile devices used for clinical workflow. So Brian, I know that you have a lot to say about that.
Yeah, and part of the complexity there is what do we do with those mobile devices in terms of personal use devices? Do we require that AirWatch or Zen Mobile or Intune clients be deployed and managed by the organization? But really that's caused a lot of complexity around what if that is a non-affiliated physician that floats between health system to health system? Does that mean they have to be managed by two separate organizations? And so with that personal device adoption, we really want to pair it up with technologies that don't necessarily look to control, but provide the same safety mechanisms that you would want for your security organization. And really that kind of spins into the IT challenge of these initiatives, really. From an IT perspective, it's very easy to position new point solutions or new technologies from an IT team that makes our job easier, that makes us more agile. But really the success of these projects is driven from a user experience. So really until you gain the understanding of the complexity of the users, the workflows that they work in each and every day, and get a good feel for how we can help them achieve quicker access to data and provide the same workflows that they want to have in those same scenarios, the success of those projects are really driven from a user experience. And that's really what we from Cortec have seen, is that the more focus on the user you have, the better some of these projects are received when you roll into a production pilot. And with those same technologies that you're deploying, you're also pairing those up with a proliferation of new devices. And I think what we've seen is that over the course of the years in healthcare IT, it's very easy to add devices into a specific area, a nursing station, additional devices in room deployments. But again, that adds the burden to IT to manage them, both from a security perspective and application installs and upgrades. And really from how we as IT are challenged inside that space is we got to find solutions that drive down the number of devices but increase the usability for our users. And that's all paired into how you deliver a desktop as well as applications in those specific use cases, and really creating a desktop workflow that almost creates instant access or very fast access into not only your desktop but your applications. As paired with that, we need to have better data security. Long gone are the days where healthcare is looking to roll out auto login Windows 7 or Windows 10 PCs that tend to be harder to secure, harder to lock up when the user's not using them. It's very easy to bring data on and off of those devices. So whatever solution we're positioning for these workflow initiatives, it's got to be better from a data security perspective, for HIPAA compliance and others. And again, whatever we position there, we've got to see reduced costs and operations and IT overhead. The goal, I think, is to really understand how we shift our internal resources to more strategic initiatives instead of ongoing maintenance and redundant tasks that IT is kind of trapped in each and every day. That adds the overall cost to IT.
Yeah, very well said. Can I back you up though on one point? I think it's worth mentioning. So the optimized desktop application delivery, proliferation of devices. You mentioned a couple times different use cases. Mm-hmm. What are the typical use cases you see in healthcare?
Yeah, I think what we've seen from pre-VDI deployment is traditional Windows desktop deployed in very specific fashions that allow the user to just launch applications from them. And from those type of devices, you actually are opening up some of the security issues that I think a lot of organizations are concerned about. Also, a lot of those are Windows type of PCs with USB ports, so it's very easy for somebody to try to upload a document from a USB drive and things like that. And what we're seeing now is moving away from Windows at the edge so that we can be a little bit more secure right out of the gate, not providing a higher threat surface for users to interact with that physical desktop, but just creating a conduit to get access to the virtual desktop.
So it's common in healthcare to see kiosks
mm-hmm.
and fast user switching where the application stays open, whatever. So what's the drawback of that?
I think it's a not so much a drawback, but it's where you position those specific workflows in your organization. So there are times where you can choose a virtual technology that will pin a specific workflow to a endpoint and have that fast user switch. But in some areas, you can create the ability for roaming VDI desktops instead of healthcare, where a user might need more access to more general use applications.
Got it. So those were use cases specific to the doctors and clinicians, but would you agree that we're seeing more and more adoption of once a healthcare organization rolls out a virtual desktop to their doctors and clinicians and they see how well it works, mm-hmm. then they start looking outside of that use case into the HR department, IT, a more comprehensive adoption of VDI as a whole.
Yeah.
And there's ROI to be had there as well. You may as well, you've built the infrastructure to support it, and that's probably the costliest side of it is the infrastructure. And then once you have the infrastructure, why not support all those other ancillary to healthcare specific use cases? Right.
And I think we definitely have seen that. The low-hanging fruit for some of these projects is definitely that shared clinical space, because that probably makes up somewhere between 30 and 50% of your total device counts for a healthcare organization. And those are somewhat defined from a use case perspective. So from a Cortec side, we see that as kind of easy, low-hanging fruit to get some quick VDI traction in your organization. The next 10 to 15% are those back office type of workflows, where you're getting into some more office-based applications or accounting or payroll, things like that. Those are great candidates, including reception and some remote coding from a remote access perspective. So I think as we look across our organization, our hopes is we can virtualize everything. I think organizations are working really hard to get up towards 90%, but those that do really achieve the efficiencies that they wish to have in the project.
Makes sense. Yeah, it makes sense.
So, so from a VDI perspective, I think, historically, organizations not only inside of healthcare, but outside of healthcare have always struggled with VDI. And a lot of it was because the technology wasn't mature in 2005, 6, and 7 to really gain cost-effective traction for these type of workloads. And a lot of it was hinged around legacy type of access for desktops that are using more SAN-based environments. And a lot of that was driven towards a lot of the failures that we saw in VDI 1.0. When you tried to pair that with initiatives like dictation, how do we, in immature VDI technologies, use USB mics for dictation and the virtual channels it takes to get those applications working well from a user satisfaction, we saw a lot of failed attempts in VDI 1.0, as well as some expectations around PACS and graphics capabilities for maybe reading images where viewing images were only required, as well as trying to manage a larger and larger subset of applications across organizations and the complexity and daunting thoughts around getting all of those working in our organization. So application complexity was a big part of that. Costs were definitely a big part of that in terms of, like I mentioned before, some of the very expensive legacy SAN environments that we've had to stand up for the performance needed to get some of these environments off the ground. Believe it or not, 7, 8, 9 years ago, there weren't even the right Microsoft licensing models to make these cost effective. Though we've seen virtualization from a server perspective make a really quick traction, VDI has always struggled to make that use there. And when we've seen VDI, really natural VDI, when it talked about client OS, is its inability to get to full production. It's because we've made some decisions around 3-tier architecture there that have prohibited us to scale into the amount that we wanted to. And all that really is driven into user experience issues, right? So I don't have a personalized desktop. I can't install applications into that desktop if that use case desires it. If you're accessing your virtual desktop from one device to another, there's different looks and feels that you would have through that. Inconsistent speed and the loss of redundancy was really the industry shortcomings that we saw that made VDI 1.0 not necessarily impossible, but very complicated to get to the levels that we want to. What we've seen over the last, I would say, 6 to 7 years from a core tech perspective is we've been able to really engage with the customer from an analytics side to build a comprehensive use case assessment strategy. So understanding the applications and how the users use them will allow us to create specific use case analysis, as well as mapping to specific user types that we can really scale these environments right off the ground, when and when not to deploy things like NVIDIA vGPU, which is an exciting technology that we're doing a lot in the 3D CAD space, but not necessarily a ton inside of healthcare. Definitely a play when you're talking about video that you're viewing via the virtual desktop, as well as application layering. A lot of the tier 1 VDI brokers like VMware, Citrix of the world have really acquired technologies inside these spaces that make application layering a capability that hadn't existed before. So something very exciting that's happening, relatively new there. From a cost perspective, we're seeing those 3-tier architectures kind of go away a bit and be replaced with hyper-converged technologies. These are really more of an appliance-driven type of model where you can scale based upon a number of users and a number of user types, and then scale at your own pace very cost-effectively, as well as making kind of the infrastructure invisible on how you manage and build it day to day. From a license control and auditing perspective, there's applications that we use and software defined resources that can help aid into the onboarding of Office 365 strategies, as well as building up a capability around auditing those specific licensing models that might need to be Microsoft compliant. We've learned a really good lesson about when to leverage a specific role in our production pilot and deployment scenarios for our healthcare customers, and that's our client engagement specialist. One of the things that will make or break a project is the ability to train the users and have a good communication source that's on the ground during a deployment, as well as pilot, to make sure that the user are engaging with the new workflows appropriately, as well as the specific VDI workflows that you've kind of baked into those use cases. And then from a user experience perspective, obviously, if you can drive costs down around the edge to get away from Windows type of endpoints and get to more zero client, there's a real cost reduction there, but also gives a little bit better speed in terms of accessing the virtual desktop. And then again, having front end and back end Windows printing, location aware printing happening within that virtual desktop is key. And I'll kind of wrap this slide up with saying, because you're creating desktop as a service models for your organization, you really have to pair that up with highly redundant business continuity designs using GSLB active data center configurations.
That makes sense. So you talked about zero clients. What about Windows embedded thin clients?
Yeah, great question. So back in 2010, 2011, Windows embedded, now called Windows IoT devices, were all the rage, and people were looking at them from the point of view of, what if something happens to my back-end infrastructure? I need to have something on Windows that I can still run an app on, or still have some presence there, so we as IT can be creating downtime scenarios. Really, that's why organizations continue to look at embedded. What we've seen with a properly architected VDI environment, that the endpoints at the edge become less and less of a concern, especially when it comes down to Windows presence. So those embedded devices are not only more costly, but they're also higher from an ongoing maintenance perspective from software IT. So.
Okay. So I don't know if now's a good time to bring it up, but I will, since we're talking about thin clients. So I know that we've done a lot of research ourselves on like iGel versus Dell-Wise versus HP versus, name your flavor. And there's something special about the Imprivata agent and how they interact with those thin clients too. Can you expound on that?
Yeah, I can. So we've kind of chosen the best of breed thin client technologies out there, and a product that we support and install called Imprivata OneSign. And with that product, you have the ability to do passive proximity badge taps to an endpoint inside of healthcare. You can authenticate to your devices via a finger biometric read and scan from your finger. You can also have a lot of the different advanced workflows around token-based access. But Imprivata at a foundation is the source of that, and how these individual clients engage with that Imprivata appliance really kind of sets apart the user experience performance that those users will see. So the two different forms of I guess authentication or activity these thin clients are set into is a process called ProveID, and there's two flavors of that called ProveID Embedded and ProveID Web. The ProveID Embedded puts the onus on Imprivata to develop their stack for the thin client vendors, whereas the ProveID Web allows the thin client vendors to integrate in their own stack the Imprivata clients. So Dell is a ProveID Web where they source all of the Imprivata code and build that into their own appliance set, whereas ProveID Embedded is upgraded from Imprivata to the thin clients, putting the onus back on Imprivata.
And I imagine either one has its own pros and cons and has to be weighed out per environment and what an individual organization's requirements are.
It does, yeah. So there's some, as you upgrade or install new BIOS revisions or new software revisions, there's some special considerations you have to make with certain portions of those vendor types to allow for a larger packet stream going into those specific areas, whether they're wireless devices or wired devices. You have to be somewhat cognizant of how those are getting updated.
Got it. So when we do our use case assessments and we do an analysis of an environment, we help a customer try to make that decision.
Yep, you got it, yep.
Okay, cool.
So VDI 2.0, so really it's creating an agile work environment where you can pair hyper-converged technologies for efficient scaling and performance at the amount that you need at a specific point of time. What we've seen is organizations like to start with a pilot, say 200 or 300 users. They might buy a small contingent of their total compute space to do that. They might be setting up in multiple data centers to prove out dual data center redundancy, but it's all about the ease and simplicity of the install from a hardware software stack perspective. So we've chosen a product called Nutanix and have had a lot of great success with that, and are really excited to talk to oncoming customers that want to see some workspace agility inside their data centers. But really what the importance for VDI 2.0 is really around the application spaces. And because we have multiple different ways to deliver applications, it's pairing up the delivery strategy with what makes sense for the specific use case. So say, for instance, we're an Epic shop and we might want to deliver Epic from a VDI client OS device. We might make a decision to install that application directly in the image, whereas opposed into a presented desktop, we might choose to layer that into an RDS image and deliver hyperspace through those means. So we can present applications, layer applications, and virtualize applications in different means, and it's really understanding when and when not to deploy those specific scenarios that makes VDI 2.0 a little bit more attractive as we look into adopting those technologies. Improved personalization as well as security, so pairing up solutions from Avanti as well as the ability to get into deeper security workflows with Imprivata allows us to really make the environment work for the user and to be efficient and even more secure. Whenever you're looking at any virtual desktop technology, especially in healthcare, printing has to be paid special attention to. And when we look at printing, we want to not only judge back-end printing from our EMRs, EHRs, but we also want to look at what does it take to create location-based printing awareness into our virtual desktop as users move their desktop from floor to floor, building to building, or even unit to unit. So changing those printers become a key important aspect of that. But what we're seeing as the new technology is secure pull printing or badge release printing, where we can actually tap our badge on a printer and select the print job that we want, and even create workflows where we're delegating printing capabilities to our nursing or clinician users from a physician perspective. And then integrating required EPCs workflow support. We'll get a little bit more into that in a later slide, but electronic prescription of controlled substances is an important workflow that we're integrating here a lot at CoreTech, and what specific workflows are entailed in technologies into that. And most importantly, as we work with a lot of customers inside the cloud space, Microsoft, Azure has always continued to come up as a potential target for our VDI workload. And when not to just kind of adhere to public and hybrid cloud strategies is really where I think the next frontier is when we look at virtualizing our desktops. And we're actually having some great success inside and outside of healthcare on those virtual desktop strategies for hybrid cloud and public cloud scenarios.
That's exciting.
So getting back into EPCs, so for those who aren't aware, electronic prescription of controlled substances have been really developed from a state perspective over the last, I would say, 6 to 7 years. Ohio was one of the first with their Board of Pharmacy rule, and then New York became second with their ISTOP state mandates. And over the past, I would say, 3 to 4 years, we've seen other states jump on, like Maine, Connecticut, North Carolina, with some pending state legislation in place. But what this really is driving for is a deadline to comply from a state perspective. Next slide, Hannah. But really what we're looking to, oh, did we miss a slide there? I'm sorry. Okay, go back, I apologize. So what we're looking for is by January 1st, 2020, all states will be mandated federally to comply from an EPCs rule, and from a DEA compliance perspective, there are specific ways to authenticate for that second factors and some that are not allowed. So that bill being introduced in June 28th is expected to go in effect January 1st, 2020. So if you're not thinking EPCs for your current workflows, now is the time to start thinking about those.
So most EMR packages, or at least the biggies, Epic and Cerner, they have EPCs workflows built into their packages already, correct? So it's a matter of aligning your back-end strategy or technologies to basically plug into what they already have in place?
Yeah, the workflows exist for EPCs, but it's really pairing in what you want to allow and not allow to be compliant. Some choose and like to have physical tokens that they deliver to their end users and are forced for the end users to type in a key to get access to that second factor. Some are using soft tokens, but there's a lot of enhanced workflows that we're working on, leveraging ConfirmID from Imprivata that allow us to do more advanced technologies like fingerprint for second factor, as well as new hands-free authentication, where a user is pairing their personal phone device with a soft token, and the device recognizes how close that user is during that second factor off.
So true hands-off pairing or communication with your device.
Yep.
That's exciting.
That is exciting.
That's a game changer.
Mm-hmm. So for EPCs workflows, it's a product called ConfirmID, and it's basically a subset of products underneath a ConfirmID license that allows for both remote access, for users gaining access to their virtual desktop external of the healthcare environment, providing the ability to do SMS passwords back from Imprivata, as well as linking into third-party applications like Duo or Azure MFA. So leveraging remote access solutions to get access to our Horizon View or Citrix-based desktop solutions that are served on-prem or in the cloud is an Imprivata ConfirmID license that we could prescribe. This also goes into effect for EPCs. We talked a little bit about hands-free and the ability for users to use their personal phones as soft tokens. The great thing about this is that the enrollment data that a physician enters into at time of enrollment, they're enrolling their badge as well as their phone in a single process, and Imprivata is what controls that enrollment data. That's usually handled by a third-party witness in those EPCs workflows, so they're checking the physician credentials and then enrolling those physicians into the system with all the different modalities that are supported. So whether it's a soft token, a hard token, hands-free, or a fingerprint, we can encapsulate the workflows we want at time of registration, as well as looking at other ConfirmID workflows for like medical devices. So we're seeing a lot of interest in creating a badge tap or second factor authentication in like medical med carts, so that if a user wanted to put their fingerprint down and open up a specific med drawer, those workflows are audited and tracked in appropriate ways.
Wow.
Mm-hmm. So some of the workflows from an analysis perspective comes from an identity proofing. So obviously you can have third-party credentialing or credentialing internally, and how that spins into how you create your supervised enrollment and witnesses. And then it's really important that the solution that you choose there is not only creates all the different type of authentication mechanisms that you want, but it's also to have a system in place where you can have great auditing and reporting. And I think the key factor of that is knowing the systems that are being put into place so that you can build the correct audit and control access mechanisms that you need to be compliant as an organization. So I really like this slide because it shows the different ConfirmID supports for EPCs requirements and all the allowed, what is referred to as a modality or Imprivata modality. So we start at the top, we have remote access. So inside of that ConfirmID solution, we can use a push token, a soft token, a hard token. We can use a password or an SMS pass. But you see for SMSs, that's the only type of workflow that's allowed from an Imprivata workflow perspective. And then EPCs, you'll notice that we can't use badge or SMS pass because they're less secure there. So creating and choosing the right second factor for the specific workflow that you want is a great way to become aware of what you can and can't create inside of your clinician-based user experiences.
So the bottom line is, once someone goes to full production deployment with a VDI solution, they're reaping real benefits. So along with real ROI and typically 12 to 18 months, not including soft savings. That's just savings that we see from shortening the device life cycle and replacing PCs with thin clients. But from the doctor-clinician point of view, we see on average that a doctor will save up to 6 minutes per patient in their daily rounds. That does nothing but increase the satisfaction rate of the clinical staff all the way around. It also makes for more accurate charting and accountability. So it's interesting, when we've done these use case assessments, I've even been places where I've seen where if there's not an easy workflow to deal with, I forgot what they call it, but you save the information and then you chart all at once, or you pre-chart. You pre-chart or you post-chart after you either saved up a bunch of patient data, and then I've seen it happen with my own eyes. They post-chart, and then it's like, oh gosh, was that Joe Smith in bed 1, or was that Mary Warren in bed 2 that had that? And, you know, mistakes happen. So being able to give immediate access at point of care makes for a lot accurate, more accurate charting. Mm-hmm. So much more HIPAA compliant for sure. I talked about the improved financial metrics. Again, we're seeing proven ROI by also deploying up to 30% less devices. This is something else that we've seen. We put VDI on in the desk at the endpoints, and then watch the environment for a while, and then you start to see over time devices that just don't get used because they're just not needed. And so what we see clients do is that as old PCs die, maybe PCs that have been converted to thin clients, or as they die, they just don't replace them because they don't need them anymore. Mm-hmm. So you can get by with up to 30% less devices. As I mentioned, the time between PC refresh cycles can be doubled at least. With some customers, we see a typical PC refresh rate of 3 to 4 years, and a typical thin client refresh rate of 6 to 8 years on the minimum, or 10 or until they die. As I mentioned, just looking at hard savings only, a full IT investment paid off in about 12 to 18 months. And then if we take into consideration the soft savings of the time that's being saved by the doctors, we see ROI of less than 12 months. As far as improved security, just an overall improved security posture and immunity from malware and ransomware. We've seen entire hospitals who had VDI slated for, 2 years from now, it's in the budget, and then get hit with ransomware, and then reshuffle the budget and make it a VDI their first project because it completely protects them against ransomware. Let's see, we talked about strong authentication, automatically locking unattended workstations, eliminating generic IDs and sharing IDs, and then most importantly of all is centrally managing everything, centrally managing your data, access, devices. We see a reduction in IT FTEs being required. And to your point earlier, Brian, what do we do with the reduced need for FTEs? Well, we repurpose those valuable people for strategic objectives instead of the maintenance that they spin their wheels on. So we have some great lessons learned to be shared, and they're worth sharing with everyone. So when we talk about, what does it take to get to full adoption? First of all, why do we want to get to full adoption? Because that's when you realize your full ROI payback is when you're at full production. And not just full production for your clinical, but even you want to go above and beyond that, full production into those other use cases outside of clinical. So what does it really take to get there? This is what we've learned. First of all, it starts at the top. You need stakeholder support. You need to have the backing of the CEO, the CIO, the CTO, the people who've done played with the budgets, looked at the ROI ahead of time, and have made a firm commitment to this project, because they'll see you through when things get stuck. For the production pilot, you need a strong PM who understands the solution and who has the authority to take ownership as they're overseeing a production pilot. So someone who has some authority, who has the backing of a stakeholder that can, demand things when needed to get things done. The third bullet, over communication to end users. What we have learned to be truly successful is you start that communication to the end users before they even get the solution. So as the team is building the solution in the back end, you have teams of people who are going out there and evangelizing this new solution that the users are about to get, to create that excitement and to help them internalize it. You know, the adult brain learns a lot different than the child brain. You need to be exposed to something at least 3 times to be able to internalize it and to start to accept it. So to be told about it, to read about it, to see it, touch it, feel it, talk to your peers about it, it goes a long way into building that excitement and acceptance before they even get the solution, so that when they do get it, they know what to expect. They've already kind of been able to play with a prox card to know how they tap in, how they move from workstation to workstation. All of that plays into a successful adoption once they get it. The other reason it plays into that is when you're in a production pilot, if there are any blips in an application didn't launch right or something, you want the patience of that end user as well to say, oh, okay, well, that's what a pilot is about. This is when we're going to shake the bugs out before we go to full production, which means, plays into those next couple of bullets there. You need stellar help desk support, and not just help desk support, but during that production pilot, level 2 and 3 support as well, so that if there are any little blips in that initial rollout, they are managed immediately and straightened out. And with that, you get happy users who then champion that solution to everyone else into the organization. The other thing that's critically important is training for the IT staff and the new technologies. Now, we've gone above and beyond on that as well, and we've done it through the CES role. So again, even before we go into production pilot, we work with the IT staff, the local help desk support. We walk through scenarios, sample FAQs, what are going to be the common things that people might call in with, and just give them a comfort level about what they're about to experience when this new solution is rolled out, and make them truly a part of the whole solution. The other key thing that we've learned, and this is kind of funny, when we talk to healthcare organizations who attempt to do VDI on their own, it's common to approach it with, well, let me start with a device in every department so everybody can experience it, as opposed to just picking one department or one floor to roll out to. I can tell you now, picking one device in every department across the hospital is the worst way to go. The biggest reason is that it mixes the workflow. You need to start with just one department where everybody in that department and everybody coming in and out of that department. So think about your respiratory folks. They are everywhere across the hospital organization. As they're coming into the department that has VDI, you want to make sure that their applications are enrolled as well. So as they're coming into a department that you've chosen as your production, your pilot floor, that they have access to the applications as well. So the key there is to not mix workflows for users. Get a successful deployment in one department, everybody that's part of one department, and then grow it from there. And then the other key thing is once you've gone through a successful production pilot, which usually lasts about 2 weeks, then you're ready to roll out into full deployment to the rest of the organization, floor by floor, department by department, based on the application sets and who has access to those applications. That's when it's time to leverage a strong partner to achieve that full deployment as quick as possible. So in some scenarios, we've seen full deployment, 4,000-ish users in less than 6 months. And that's when you realize the full benefit, the full ROI is when you get to that full production. So again, from our lessons learned, this is how we approach VDI today. Number one, we start with our clients to create the value propositions to assist in the pre-budget approval process. What do we mean by that? We have created our own ROI and TCO tools, and we start with a framework, and then through an interview process, we understand What are the key data metrics that are important to you? What is your PC refresh cycle? What is your move adds and changes schedule look like? What are your maintenance windows? What, all those metrics. How many doctors do you have on staff? How many are employed by the hospital compared to the independent ones? And where do they come in from? And what's their workflow? We take all those things into consideration, and we create your own custom ROI template, and then we hand it over to you to play with. Do your own what-if scenarios. And that part alone is key to getting stakeholder support for them to be on board and realize that there is an ROI here and it is achievable. The next step, once we've gotten past that hurdle, is a use case assessment that focuses on the end user workflow. Brian, you mentioned that a little bit too. I think what's unique about the way we do use case assessments is the interview process. Not only do we put tools in the environment to capture data about the network bandwidth, what applications are in use, when is the heavy times, and how many users are logging in at one time, and what time of day, and that sort of thing, but equally critical to marrying up against that data is the interview process. So we ask you to choose people across various departments, your toughest users, along with your champions, and we follow them around with a clipboard. We understand their workflow. We ask them what they like, what they don't like, and they like to be heard. And that's the kind of feedback that we get. They like to be heard. It goes a long way once you do roll things out, that they know that they had a say in how that solution was customized to accommodate their workflow. The next thing is, CoreTech gives a performance guarantee. We'll put it in writing. We can guarantee that your initial logon of the day will be 30 seconds or less, and then subsequent logons after that will be sub 10 seconds. And we are able to achieve that through some of our own IP that we didn't even talk about today, Brian. We talked about this a little bit too, the client engagement specialist that drives user communication and full adoption. I cannot underscore the importance of that role. They are the cheerleaders that are in there while the solution is being built and long after the solution has been deployed, sharing lessons learned, listening to users, creating placards, training the IT staff on FAQs and all of that, but just creating that excitement, that buzz, and educating everyone on what they're about to experience and how much better it's going to be. CoreTech has a 100% success rate in taking VDI environments from pilot to full production. I don't know of any other organization in the country who can say we have a 100% success rate. It's something that we're very proud of. Mm-hmm. And then again, to drive to full production, we mentioned it already, we have a mature managed services division to help drive that. And it's worth saying that 12 years ago, we didn't have that. That's one of the lessons learned, that we figured out that if someone really wants to get to full production, they need some help. And so as a result, we have matured our managed services to meet that challenge and get people to full production. A couple of happy customers, Munson, Texas Tech, just a couple. I think we're running up on time, so we'll just keep going. Oh, and I think that's the end of it then. So I want to mention that we do have a part 2 and a part 3 coming up, back to the basics, where we're going to talk about all the new technologies today that make VDI version 2.0. And then part 3, how to optimize your environment. And I think that's where we're going to expound a little bit on some of the tools that we've created that help us really optimize those environments. So Hannah, I see that we have a couple questions here, and they look technical, so I'll just ask Brian. So Brian, one of the questions we had come in is, what is the most common VDI broker for your healthcare customers? And what we're referring to is Citrix versus Horizon.
Yeah, that's a great question. So the great thing is that from a CoreTech perspective, we do both, and we've built practices around both technologies. And I think what we see right now is about a 60-40 split between Citrix and VMware. And I think from a CoreTech perspective, we've seen Citrix a little bit more, only because the customers that we engage with have already owned a large portion of that product. And that's where we help and educate, the cost models and pair those up successfully to not rip and replace, but use some of those investments that are already already achieved to kind of position the right use case and the right technology at the right price. But there are efficiencies, pros and cons of each, and different deployment methods and models to do. But the great thing is that CoreTech has chosen technologies that pair up with each of those for both successful deployments for both.
So do customers ever deploy both?
In a small occasions they do. We've seen some customers choose Horizon View and do all VDI, and then jump into, say, like their Epic Hyperspace that is deployed through Citrix. However, a lot of organizations are looking to combine or define the specific licensing model to decrease cost year over year. So sometimes it makes better sense to pick a horse in that race and understand how you can drive lower cost efficiencies through that.
Got it. Makes sense. All right, another question. Are your customers leveraging cloud for these workloads? I would add to that, and if they are, which cloud are they leveraging?
Yeah, no, it's great. Great question. And actually, over the last 24 months, we've been helping companies realize some efficiencies of the public cloud. Most of our work that we've been doing is in Microsoft Azure. And the reason why that is that Microsoft and Citrix have worked really aggressively together to create specific solutions that are Win 10 compliant from a licensing model and driving towards public cloud adoption where Windows workloads work very well in Azure, right? And so understanding those VDI plays and when to do Zen App or Zen Desktop, Azure has always been kind of something that customers have already owned and wanted to leverage. So we've helped customers achieve those same type of workflows in Microsoft Azure. I will tell you, we're really excited since VMware this year that VMware Horizon View did announce some potential support in their roadmap for Microsoft Azure, so we're really excited to see that come up, as well as all the integration that VMware is doing with AWS natively inside of their own hypervisor stack. So we're always keeping an ear to the to the grindstone to understand where the technologies are swinging and how we need to be on top of those.
That's awesome, and you're obviously incredibly knowledgeable about this space, so I can't thank you enough for joining me today in this discussion, and I hope everyone can join us for the next two coming up. So as Hannah mentioned at the beginning, we will send out the link to the recording for this webinar, and it will be available for anyone who misses it, who wants to still join on part 2 and part 3. So Hannah, thank you so much, and Brian, thank you.
You're welcome. Thanks.